speaking on the imaging of pediatric hematological disorders. These are divided as disorders of the red blood cells, white blood cells, coagulation mechanism, and platelet disorders. The red blood cell disorders include inadequate production, which are congenital erythropoietic anemia and aplastic anemia due to multiple etiologies, increased production, that is polycythemia vera, hemolysis, which is hereditary spherocytosis, hemoglobinopathies, which are inherited disorders of the hemoglobin, such as sickle cell anemia and thalassemia, immune-mediated hemolysis, which includes erythroblastosis fetalis and other chronic anemias, such as Fanconi's anemia. The white blood cell disorders are leukemia. In the pediatric age group, it is mainly acute lymphocytic leukemia and acute myeloid leukemia. Coagulation disorders are hemophilia, von Willebrand's disease, and DIC. Platelet disorders are idiopathic thrombocytopenic purpura. Starting with the red blood cell disorder, the congenital dyserythropoietic anemia is a group of inherited conditions characterized by maturation errors during erythropoiesis. Decreased reticulocyte count is seen in contrast with erythroid hyperplasia in the bone marrow. The symptoms and signs are of variable anemia, increased hemoglobin turnover, and mild jaundice. The most prevalent complications are cholelithiasis, splenomegaly, and iron overload. The long-term complications include secondary hemochromatosis. There is a parenchymal pattern of deposition of iron. The excess changes the and sickle cell anemia, normal abnormal hemoglobin get to function in my life. Have no over so in Peter appears and radiology in areas of medicine and talking about and radiology population along with the found in femur, tibia, and humerus. Imara is the preferred modality of in narrow contrast, Gila is most sensitive and specific and shows areas of abnormal enhancement. It is in lab optic edema. However, imaging alone does not allow reliable and accurate differentiation between osteomyelitis and infarction. Lower critical task, diffuse periostealitis the lower half of the diaphragm. In the lungs, it can present as uh, due to impaired immune state. The acute syndrome may be also due to fat emboli or pulmonary vascular occlusion. On X-ray, single or multiple areas of pulmonary consolidation. Uh, uh, Findings include which are due to repeated episodes of pulmonary insults causing pulmonary fibrosis, which is usually focal, pleural scarring, and pulmonary arteriolar intimal hyperplasia, resulting in pulmonary hypertension. So CT shows septal thickening, dilated secondary pulmonary lobules, traction bronchiectasis, and architectural distortion. In the brain, ischemic infarction can result from sickle cells in the vessels. Some of the infarcts may be clinically silent. Screening transcranial Doppler ultrasound is often performed to assess the large cerebral artery flow. Elevated velocities in the distal internal carotid artery and prog artery that is greater than 170 to 200 centimeters per second correlate with an increased risk of stroke. The preventive therapy of for stroke includes maintenance transfusions. There is also reduced, because of the reduced cerebral blood flow, there is development of fine collateral vascular channels, usually from the thalamoperforate and the lenticulostriate arteries. In children with sickle cell anemia, even as early as 4 years, the cortex, thalamus, and the caudate nuclei exhibit lower T1 relaxation times. These T1 abnormalities are larger than white matter abnormalities, and this suggests that the gray matter is selectively vulnerable in pediatric patients. And these abnormalities on the MRI correlate with cognitive impairment often seen in these children. The spleen is susceptible due to congestion and sludging because of its low tortuous microcirculation, which results in splenic infarction that progresses over time to functional autosplenectomy. 95% are asplenic by 5 years. This increases the infection susceptibility. The infarcted spleen is replaced by fibrosis, calcium, and hemosiderin deposition, becomes small, dense, and calcified. Sequestration syndrome is another another pathology which is seen, which results from rapid pooling of blood within a solid organ, which is almost always the spleen, and it has also been reported in the liver. This results in a large intravascular volume depletion and dropping hematocrit values. In a severe episode, there is a rapidly enlarging spleen which progresses to cardiovascular collapse and death. On imaging, the spleen is larger than expected. Since most older children have splenic autoinfarction, a visible or a palpable spleen of apparently normal size may actually indicate an enlarged spleen. On ultrasound, it is seen as a heterogeneous spleen with hypoechoic areas at the periphery, and CT also shows low attenuation peripheral areas. This is an example of sequestration syndrome with splenic infarction and shows an enlarged spleen with heterogeneous enhancement. In the kidney, because of increased renal plasma flow and increased glomerular filtration rates, it results in glomerular sclerosis, which leads to proteinuria, nephrotic syndrome, and sometimes renal failure. Capillary obliteration and medullary necrosis of the papillary tips manifest as papillary necrosis. 50% of patients with sickle cell anemia have large kidneys, which is believed to be because of the increased renal blood volume from anemia. Spleen is also frequently involved. There may be perisinusoidal fibrosis, ischemic necrosis, and cirrhosis due to the infarction. Extramedullary hemopoiesis is occasionally seen. The other condition is thalassemia syndrome, which is a genetic disorder involving the globin gene that is reduced to absent globin chain synthesis, alpha or beta, and result in globin chain imbalance. Consequently, there is ineffective erythropoiesis, which causes severe anemia, hyperactive marrow, significant extramedullary hemopoiesis with secondary skeletal deformity, and hepatosplenomegaly. Severe form is known as most severe form is thalassemia major. Radiological findings include marrow hyperplasia, which is seen as trabecular destruction, expansion, and thinning of the overlying cortex. In the hands, the changes appear first with biconvex shafts of the phalanges and metacarpals. Similar abnormalities also appear in the feet and ribs. There is also apparent failure of modeling in long bones, seen as a flask-shaped femora. In the spine, a coarse trabecular pattern is seen. An example of uh, thalassemia showing changes in the hands, widening of the medullary cavities, thinning of the cortices, and tubular appearance of the bones. The major trabeculae appear coarse with loss of the finer trabeculae because of the marrow hyperplasia. This is a flask-shaped appearance of the femur with dark marrow signal on T1 because of the marrow conversion from red to yellow, from yellow to red, and on the PDFS it is bright. There is exaggerated trabeculae with slight bone expansion. In the skull, there is overactivity of the red marrow in response to the anemia. This marrow hyperplasia widens the diploid space and thins the outer table, starting in the frontal region with relative sparing of the occipital region. There is trabecular destruction with thickening of the residual trabeculae. The hyperplastic marrow thins the outer table and it proliferates under the periosteum, and new bone spicules are laid down perpendicular to the inner table. The alternating opaque trabeculae and the radiolucent marrow hyperplasia produce the hair-on end appearance. Skull changes are more severe in patients with thalassemia major than those in any other condition that produces marrow hyperplasia. There is also impaired development of air spaces in the skull, especially maxillary antrum and mastoids, due to the marrow hyperplasia, giving a rodent facies. This is an example of marrow hyperplasia giving a hair-on end appearance on the X-ray, and also the sagittal MRI shows the same findings with alternating bands of hypointense trabeculae and the hyperintense marrow. Erythroblastosis fetalis is an immunological incompatibility between the blood of the mother and fetus. It is usually due to Rh fracture. It can be from a mild anemia to icterus or hydrops. The skeletal changes include transverse metaphyseal lucencies in the long bones. Hydrops in the fetus is seen as retarded growth, extensive effusions, and diffuse cutaneous edema. Fanconi's anemia, it's a rare autosomal recessive inherited disorder characterized by progressive bone marrow failure and various congenital abnormalities. It is the most common type of inherited marrow failure syndrome. It presents as aplastic anemia, myelodysplastic syndrome, and AML. Pancytopenia develops by 5 to 10 years. There is a predisposition to malignancies like acute myeloid leukemia. Also, solid organ tumors may develop in early adulthood. There are also some associated congenital anomalies with this condition, which include horseshoe kidney, radial ray anomalies, absent thumb, and triphalangeal thumb. Skin pigmentation, growth retardation, and developmental delay may also be seen. This is an example of complete absence of the phalanges and metacarpal bones of the thumbs bilaterally. Leukemia. Acute leukemia is the most common malignancy in children. The age of involvement is 2 to 6 years. Chromosomal abnormalities such as Down, Bloom, Fanconi syndrome, and ataxia telangiectasia are prone. Leukemia may present with pallor, petechia, ecchymosis in the skin, and mucous membranes. It should be suspected when there is fever of unknown origin, bone pain not associated with trauma, spontaneous bruising associated with minor trauma, nasal or gingival bleeding, recurrent infections, and lymphadenopathy persisting for more than 4 weeks, and splenomegaly. Bone involvement is seen due to the widespread red bone marrow in children. More than 50% of the children show the skeletal abnormalities. It may affect any part of the skeleton, such as pelvis, vertebrae, long bones of lower extremities. These are the most commonly affected sites. Growing skeleton is an important site for proliferation of the leukemic cells. Hence, multiple areas of bone destruction and repair are seen due to infiltration of leukemic cells in the bone marrow. On X-ray, radiolucent fine transverse metaphyseal bands are seen, which is the most common finding suggestive of leukemia. However, under 2 years of age, it may also be found in other chronic diseases which alter osteogenesis. These bands are usually located in the proximal and distal humerus, distal femur, the femur being the most frequent site. Also, wrist and ankle are affected. There is local or diffuse osteopenia that may present with back pain or lumbar pain due to vertebral collapse. Focal and generalized osteolysis of long and flat bones, that is skull, pelvis, ribs, and shoulder girdle is also seen, which has a moth-eaten appearance or bone rarefaction caused by presence of small lytic areas with ill-defined margins. Metaphyseal bands and osteolytic lesions may be observed in up to 70% of the cases, whereas osteopenia is seen only in 25% and fractures only in 10% of the children. Metaphyseal cortical erosions are seen in the medial aspect of the proximal humerus and the tibial shaft. Periosteal and subperiosteal reaction corresponding to areas of thickening of the periosteum due to the new bone formation. Osteosclerosis of metaphysis is a late and infrequent manifestation. Other manifestations include soft tissue swelling, juxta-articular osteoporosis, and joint effusion. This is a case of leukemia where we can see metaphyseal lucent band in the epiphysis, the metaphysis. Then there are also some ill-defined lucent lesions, the first and the third metacarpal bones. Acute lymphocytic leukemia, this is the most common malignancy less than 15 years of age, accounts for 80% of all leukemia cases. There is a male predominance. Hepatosplenomegaly is seen in 60 to 70%, and lymph nodes in the cervical, axillary, or inguinal region are seen in up to 50%. Lymph nodes are usually hypoechoic on ultrasound. Acute myeloid leukemia does not show any sex predominance. Hepatosplenomegaly is again seen in 50%. Enlarged lymph nodes are seen only in 25% of the patients. In ultrasound, the liver and spleen show decreased parenchymal echogenicity. There is also involvement of sites other than the hemopoietic organs and skeleton, but it is uncommon at presentation of pediatric leukemia. However, sanctuary sites such as CNS, testes, and kidneys are affected in 50% of children who relapse after therapy. The findings include bilateral enlarged kidneys, which show increased echogenicity of the renal parenchyma. CT scans reveal multiple low attenuation areas. On mediastinum is involved in cases of ALL. 60% show mediastinal lymph nodes. An anterior mediastinal mass is seen on the X-ray and CT scan. Differential includes lymphoma. Breast involvement in leukemia is seen as a breast lump, usually unilateral. On ultrasound, they appear as hypoechoic nodules. Infiltration of the testis occurs under 20 years of age. Primary involvement is rare and it is usually a site of recurrence. On ultrasound, enlarged testis with multiple nodules or more frequently diffuse involvement with increased or decreased echogenicity is seen. This is an example of scrotum infiltrated with AML, with testicular involvement showing hypoechoic and heterogeneous enlarged testis. CNS manifestations include hemorrhage due to alterations in the coagulation factor, which is most common in acute leukemia and often leads to death. Patients with fulminant leukocytosis, that is blast crisis, leukostasis, or blast cell thrombi within the small arterioles can produce vascular damage and massive hemorrhage. Leukemic cells can also involve the calvarial bone marrow, dura, and leptomeninges. Involvement may be diffuse or focal with abnormal meningeal enhancement on CT and MR. Parenchymal Parenchymal leukemic masses are very uncommon and often hyperattenuating on CT, contiguous with a meningeal surface and enhanced after contrast. Granulocytic sarcomas, also called chloromas, are seen, which are masses of primitive precursors of the granulocytic cells. They mainly occur in children with AML. It may be a presenting sign of AML or develop during the course of the disease. Head and neck leukemic masses are common in the orbit and seen as focal intra or extracorneal masses. The extraocular muscles, optic nerve, and intraocular involvement may be seen. Enlarged optic nerve with enhancement is seen on imaging. Spine is involved either in initial manifestation or in relapse. On MRI, low signal intensity leukemic infiltrates on T1, especially in areas of red marrow, is converted to yellow marrow. This is an example of ALL with fulminant leukocytosis showing multiple hemorrhagic lesions in the corpus callosum and the cerebral white matter with intraventricular extension. This is an example of AML with orbital granulocytic sarcoma in a 1-year-old. It shows a left orbital mass. Another case of ALL, the CECT shows an enlarged enhancing left optic nerve. Involvement of spine in acute ALL in a 3-year-old boy, diffuse T1 hypointensity on the in the lumbar spine, consistent with this is a in contrast to it, this is a normal healthy 3-year-old boy which shows higher T1 signal intensity of the vertebral body in relation to the disc space. Hemophilia A and B are X-linked genetic disorders. Hemophilia A is due to the deficiency of the clotting factor 8, whereas B is due to the deficiency of the clotting factor 9. The most common manifestation of hemophilia is hemophilic arthropathy. This is due to repeated bleeding into the synovial joints and subsequent arthropathic changes. The most commonly affected joints in descending order are the knee, ankle, elbow, and shoulder. Bilateral involvement is common. This most often occurs in the first or second decade of life. This is because of bleeding episodes which tend to recur in the same joint and cause synovial hyperplasia, chronic inflammatory changes, fibrosis, and siderosis of the synovial membrane. Radiographic findings vary with different stages of arthropathy, that is acute, subacute, or chronic hemarthrosis. Findings include hemarthrosis or joint effusion, synovial inflammation and hyperemia, which is seen as osteoporosis and epiphyseal overgrowth, chondral erosions and subchondral resorption, seen as osseous erosions and cysts, cartilaginous denudation and osseous proliferation, seen as sclerosis and osteophytosis. The characteristic findings in chronic hemarthrosis are abnormalities of the osseous shape, such as widening of the intercondylar notch, flattening of the condylar surface, and squaring of the patella. On MRI, hypertrophic synovial membrane due to repetitive hemarthrosis is seen, which has a low signal intensity on all pulse sequences, especially in GRE, due to the magnetic susceptibility effect of hemosiderin. Signal intensity of the subarticular defects varies and may indicate presence of fluid, that is high T2, soft tissue intermediate signal intensity, or synovial tissue with hemosiderin, that is low signal intensity. This is an example of arthropathy in the knee, which shows osteoporosis, epiphyseal enlargement, irregularities of the subchondral bone, and a widened intercondylar notch. And on the MRI, there is hypertrophy of the synovium. This is a late manifestation which shows the destruction of the cartilage, and there are also subarticular cystic areas with hemorrhagic rest, collagen and or gelatinous tissue in these cases. Musculoskeletal involvement includes repetitive bleeding into the muscles which cause joint contractures or soft tissue pseudotumors, and bleeding into the bones which result in osseous pseudotumors. Subcutaneous hematomas are also seen. Hemophilic pseudotumors are encapsulated chronic, slow expanding hematoma in patients with a severe coagulation disorder, which can be in the soft tissues, it can be osseous or subperiosteal. It consists of blood products that are in various stages of evolution and has a fibrous capsule that contains hemosiderin-laden macrophages. It can cause bone erosion and pathological fracture. It can also become calcified or ossified. Infection is a potential complication. On MRI, heterogeneous low and high signal intensity areas are seen within the pseudotumor on both T1 and T2, representing blood products in various stages of evolution. This is an example of giant pseudotumor of the distal femoral epiphysis. Shows a heterogeneous density in both the sagittal and the axial images. These are some of the references I used for my talk. Thank you.